go through some of the fire procedures. In case of an emergency, there are no planned fire drills during this meeting. If you hear the fire alarm sound, please treat it as a real emergency and evacuate the building via the nearest safe escape route. The nearest escape route is via the stairs to your left as you leave the council chamber or public gallery. Exit via the door at the back of the building and walk across the inner car park to the evacuation point, which is the pavement opposite the police station. The lifts can't be used in the event of an emergency. Please do not re-enter the building until you're advised it's safe to do so by a member of staff. Welcome to everybody to our meeting. I'm just going to run through a few things before we get to your part of the agenda. Apologies and substitutions. Councillor Debbie Andre has given her apologies, but she has a substitution in Councillor Mark Jeffreys. Welcome to our committee. It's nice to see you here. And we have apologies from Councillor David Adams. There is no substitution. I think that's it on apologies, isn't it? Has everybody read the minutes of the previous meeting? Does anybody have any changes to their meeting, those minutes, or are you happy that I sign them as read? Are we all happy? Can we just have a show of hands for those that were at the meeting? That's lovely. Thank you. Declarations of interest. I do believe that we have a declaration of interest this evening for the first part of our agenda, which is the health scrutiny part. Councillor Price.
Thank you, Chairman. Yeah, I have a close family member that works in a financial role within an organisation, so therefore I will remove myself from the chamber for that item. Thank you.
Just want to check this with Mr. Gard. I spoke to Mr. Councillor.
Chairman, is that necessary?
So
I mean, we all got interest on the Isle of Wight. You can't go anywhere without. I would object to Councillor Price leaving the chamber.
Let me just check this with Ben.
Chairman,
I did speak to Councillor Price this morning, and he's a very close member of his family that doesn't just work within an area of this subject, but actually works in the finance department. So I did feel that, you know, it wasn't really appropriate that he joined in when this is really about finances. So that's how
I have spoken with Councillor Price just before the meeting, and it is a matter entirely for him to make that judgment call. I believe he's comfortable with that judgment call, and I'm very happy to leave it with him. Chairman, so if he feels the interest is such that he'll need to remove himself from the room, that is a matter for him, and I'm happy that to leave that with him.
It is entirely up to you. If you're not comfortable and it makes whoever is the person that you are close to, then I'm happy that you do that. We don't want anybody to sit through this meeting if you're feeling uncomfortable, feel that it's going to prejudice in any way. You should not attend a meeting and then feel that you're actually going to be made uncomfortable, or a family member made uncomfortable. Is that okay? So entirely up to you, Councillor Price. Go home and have a beer if you want. So we've done declarations of interest. Public question time. There are no public questions. Members' question time. We do have one written question, and I will read it out and then I will give the response. It's a written question from Councillor Michael Lilly to myself, Councillor Claire Mosdale. As electric convulsive therapy is still actively administered at 7 acres, 58 patients in 2024 and 11 so far in 2025, does the Hampshire and Isle of Wight Healthcare NHS Foundation Trust, in light of the recent publication of the largest ever survey questions, ECT's effectiveness, University of London, and there's a Google link, I don't need to read that out to you, come to the conclusion that ECT is in fact ineffective and leads to long-term memory loss, that the use of ECT be seriously reviewed and should be phased out. It says, personally, I'm shocked that ECT is still being used as extensively on the Isle of Wight. 58 patients may not seem high, but within the population of 140,000 and a total of 2,500 ECT patients across the UK, 58 is considerably high. ECT patients are primarily women. This continued use of ECT, in my view, is barbaric and based on poor medical psychiatric evidence. So my response to Councillor Lilly, who I think this is a very valid question, I did find it quite scary myself when I read it, is we don't have anybody who's been approached this evening who can answer this question. So what we will do as a committee, if everyone's happy with that, we will send this to the Hampshire and Isle of Wight Trust, and we will ask them for a written response to this committee. And I will share that response to all members. And once we might actually decide that this is something that we need to investigate further once we've had the response from the trust. Is the committee happy with that answer? Yeah, okay. Any other members' questions before we move on? Are we happy? Okay. Right, we are going to move to the health section, the health scrutiny section. So this committee is very different to any other committees. So we are the only committee that actually has a health scrutiny section or any scrutiny part of it. I will give a set amount of time to it, and I will make sure that we are very open and fair. And if anyone's questioning gets a little bit too much, I am quite a good chair, and I'll make sure that everything is managed properly and appropriately. So it is something that is felt quite widely to lots of people on the Isle of Wight, and it's the impact of palliative care services funding for island residents, and that's pages 9 to 34 in your papers. I would like to actually do it a little bit of a funny way round. I would like to bring in Joanna Smith to start, please, because Health Watch has done a very important report. Is the committee happy with that? That we hear from Joanna first to give a bit of a briefing on the report, because there is nobody in the room who gets the voice of the actual island residents when it comes to healthcare as well as Health Watch do. Is that okay, Joanna, with you? Thank you.
Thank you. So in May of this year, we started to get a significant increase in feedback around Mountbatten, both in regards to the service they provide and also in regards to their funding. And it was significant because we were hearing from a lot of people that we'd never heard from before, and by a wide variety of means as well. So we had a lot of people writing to us, which is quite unusual. People were calling us using social media, and lots of people were speaking to us as we were doing our community engagement. And due to the level of feedback and the concerns that people shared with us, we've done a thematic review of that feedback. Because we are here to make sure that people's voices are heard. And we heard from a good number of people that are very anxious and upset about the potential funding cut to Mountbatten. We heard from cancer patients who have received treatment and support from Mountbatten services. And we also heard from people that are reaching the end of their life now, and they are extremely upset and anxious that Mountbatten services won't be there for them when they need them. So there we grouped the feedback into themes. So we received personal testimonies from people about the services Mountbatten has provided. And when we look back through the feedback we've received over the past 12, 13 years about Mountbatten, I think it's one of the only organisations that we've only ever received positive feedback about. And that's pretty unique. And I have looked back through the feedback myself just to double check that. So there's a love for Mountbatten on the island. I think that's been underestimated. There's a culture of care, compassion, openness, integrity that reaches everyone. It reaches the whole community. And people were concerned about the lack of engagement and communication around the funding. So because there was a lack of clarity around funding, it might be cut in the autumn, it might be cut in the spring. It's caused a lot of distress to people, and lots of people are concerned that there's been no engagement prior to this decision being made with local people. People were also concerned that the decision hasn't factored in the island factor. So the island is different. We don't have another hospice that we can access easily as you can on the mainland. Our hospice as well is the only hospice that provides services for children and adults. And fortunately, we don't have many children supported at our local hospice, but it's absolutely crucial that young people and children can be supported on the island by their families and friends in their local communities, and that they don't have to go off island. A lot of people were concerned about the impact on other services should Mountbatten's funding be cut. So there was a concern about A&E, GP practices, inpatient care at the hospital, because there will be an impact. And there's a concern that the island is different because we have an older population. We've got more people with long-term conditions. We have more people that live here on their own because they've retired here. So lots of people don't have family support. So there is more reliance on services like Mountbatten that provide so much of their support in the local community. So our support, our report details some of the feedback that people shared with us, and we had a huge amount of feedback. People wrote pages and pages of feedback because they feel so strongly about Mountbatten. And again, that's unique. You know, people often share their story with us, but they wanted to share their whole story. And it also demonstrates the impact that end-of-life care can have on people. We always say there are two services that are some of the most important, and that's maternity and end-of-life care. Because if you get those services wrong, the effect will stay with the person, the family, the community for life. If you have a poor birth or a poor death, no one forgets that experience. It stays with you. And that's why I think people on the island feel so strongly about this. So we've produced our report just as a thematic review of the feedback we've received, and we're still getting feedback now.
Thank you, Joanna. Before I bring in 2 questions and things like that, I will give you the heads up, James, that my question will be, how was the actual funding formula worked out? Because I do have concerns on palliative care and fragility on the island, that I'm really concerned that the ICB are doing a whole generic formula that actually covers Hampshire, all your other areas, as well as the Isle of Wight, without actually taking in the fact that we have so many elderly and so many people who are becoming near to end of life. And I think that's one of the things, a main question from the committee will be, just to give you the heads up when we get to you, is how are you producing this formula, and do you feel this formula is fair to the island, or are we being linked in with a demographic that actually doesn't show rightfully what the Isle of Wight demographics is? Because I think that's the bit that the public will really want to know, is how is this funding formula worked out, and actually is this funding formula fair per person? I, say my 85-year-old mother was fragile and would she get the same per person for her as if she was going somewhere on the mainland? And my gut feeling at the moment is the answer is no to that. I'd like to bring in the hospice, if that's okay with the committee, to explain some of their services, what you think this effect will have to you, and then I think James, then I will bring you in, and then I'll bring the committee in for some questions. Is that okay with everybody, that we work it like that? Okay, so hospice. I wanted to start with Joanna because actually it is incredibly rare for Health Watch to have a report that has nothing but praise, because human nature usually has a but. I had a really good service, but it might not even be a big but usually there is a but. There is none of that when it comes to the hospice. So you should be truly proud of what you do and what you provide to the island. So, this is our chance to try and support you to share what you do and how this is going to affect you. Also, I have no big toenail, by the way, because I did the 26 miles walk the way. I'm not going to do it again, but there you go. To all those other people who are feeling still all those months later tainted from it, we do a lot for funding as well. Let me hand over to you guys.
Joanna, thank you for that summary. My name's Paul. I'm a palliative care consultant. I moved here 11 years ago. And the thing which struck me when I moved here was suddenly, because you have a moat, anyone that dies badly here dies badly on our watch. And when you look at some hospice systems, they hide from people who are dying. And when we have visitors, and we have many from other hospice services, the feedback I consistently get is we didn't realise how many dying people we weren't seeing. So yeah, we're trying to be ambitious, and obviously nobody would want me to apologise for that, but we're involved in 3/4 of people that die on the island we're involved with. On the mainland, the typical figure would be 1/4, and that's without more staff. And I guess part of me worries about trying to keep my emotions in check this evening, because I'm really worried. Because we're, for the first time, faced with having to see people potentially die badly. And that, I can't get across how unnecessary that is. It's the medicines we use are, by health standards, fairly cheap. People need some kindness and some basic symptom relief, and we really should be able to deliver that, and we can at the moment, and it worries me greatly that being taken away. In answer to your question, clearly not. The mortality rate here is 50% higher than the mainland. And over here, the hospice, and therefore the island population, pay my wages. Over in Portsmouth, the NHS pays the medical team wages. The island pays for our community palliative care service. Over there, the NHS pay for it. Here, we have no overnight district nurse. If your mum is ill tonight, there are 2 people who would visit her at home. One is a nurse from our team, and the other would be a paramedic from the ambulance service. Both would be excellent. Both would have trained together. Both would have each other's mobile net. So we have all of those island advantages, but we're doing a huge amount that is paid for by the NHS on the mainland. So absolutely no, none of that was taken into account in how this decision was reached. But I absolutely get that's not James's personal fault, and I don't want to come across as attacking him, because that's not who I am, but I'm desperate for this to change. If I could make one further set of points. The other thing which struck me about the island is you can do things here that can't easily be done on the mainland. So there's a reason. I mean, on Saturday, I'm lecturing online over in Brazil. I lectured in Australia, in Latin America, in New Zealand, Ireland, the UK. The reason we're asked to do that, the reason that Singapore sent a delegation over to the island, one of only 6 a delegation to, and they sent that delegation because they wanted to know how could they use palliative care to help them manage their aging population in Singapore. The reason is we can do things differently. And so we were just talking beforehand, and I'm hoping that we'll be meeting after. We can really help with moving forward with the 10-year plan. That you may be familiar with the new neighbourhood, the neighbourhood health systems. I think that is an exciting development. I think the Isle of Wight ambulance service is very, very unique, and the input that we can give is unique, both of those, to support that service. And I think what that could do, that could take where we are at the moment and make it even better. Because at the moment, if somebody knows that the end of their life is coming and they want symptom control, we can do that, at least for the moment until April, we can do that. But the next population that we need to reach are people, they don't want to go to hospital anymore, but they still want some active treatment. And the techniques that we have in palliative care, we can adjust to giving, for example, injectable antibiotics in the home. You need to do that differently to the hospital. And I won't bore you with the details, but that's one of the things that I'm really frequently asked to lecture on elsewhere, because we've taken a technique pioneered in France, we've set it up here. It works really well. It's really low tech, it's not sexy, but it works really well. And so we're ideally placed to help with those things. So I'm desperate for this to be fixed, but a little bit of me is also excited because a little bit of me thinks it will be fixed. And then we're really uniquely well placed to actually move forward with the 10-year plan, I very much hope. Sorry.
Chrissy.
Thank you, Chair. Thank you, Paul. I think another thing that's really important to focus on is the model on the Isle of Wight, which Paul has just described, and it is renowned, it is held up as a model of excellence across not just the UK, but worldwide. The model on the Isle of Wight was held in such high regard that the Southampton Commissioners and parts of South West Hampshire recognise that that's the model that is required to keep people safe. And so this was replicated.
I'm just going to have to say what your job title is because I've got members asking. So it's Chrissy Dawson, Mountbatten, Head of Community Equipment.
Head of Community and Public Engagement.
And Public Engagement.
Sorry, I should have said that at the beginning. So my point is that the ICB or the CCG at that time knew that this model was the right model and have replicated. We have a hospice in Hampshire and you know, that's the same models happening there. But the other point, other than the human factor and the human cost and the impact on individuals, is the impact on the system if we're not there. The ripple effect of a poor death and people having to access 999. If you added up the cost of a paramedic going out to someone, if one of our nurses aren't there or we don't have a bed, the cost of the paramedic, the cost of that A&E episode, the cost of a non-elective admission, the cost of a delayed transfer of care, the human cost of somebody dying in hospital and the ripple effect on their family if the death is poor, the ripple effect on a family if the death is a poor death is they don't want to go to work because they feel not great. I'm going to feel emotive now, so I'm going to have to be very careful with my language. The ripple effect impacts them. So it impacts industry because people can't go to work. It impacts their mental health. It knocks on the door of primary care because they don't know where else to turn. They may then knock on our door again because we are the only bereavements, not the only bereavement service, but a bereavement service on the island. And because we all know that mental health services on the island are more than stretched, that would be an understatement, that they will be knocking back on our door. The ripple effect is huge.
Duncan, can you introduce yourself with your job title, please, so the members can see?
Yeah, of course, Claire. Duncan Fleming, Director of Quality Data and Information for Mountbatten. So really just to back up Paul and Chrissy's points, in terms of our service, and the whole focus around the neighbourhood 10-year plan and the whole focus moving forward is this shift left that we've talked about. So James and I have talked about in our recent meetings. For us, we feel Mountbatten have been doing that for the last 10 years. So we changed our referral criteria to meet people earlier, to actually get a planned approach. So it's not those last minute referrals into the service and all those complexities that Chrissy's just talked about and the impact of people, the impact on people. So we've been doing that. So the irony of the situation, it feels like, is that we're pretty much where the ICB would like to see the other hospices within Hampshire and the Isle of Wight to be in 10 years' time. We feel we're ahead of the game, and that should be replicated, and the learning of what we've been doing over the last 10 years actually discussed and implemented in other areas. I think the other thing in terms of the actual the rationale behind the actual decision making on the funding is that other hospices, that their model is different. For example, the community element in the hospice that serves Portsmouth area is funded directly by the NHS, where ours is part of that is charitable income. So that's like comparing apples with pears. In terms of the services that we do provide, just to give a bit of background on that, so we have our inpatient unit, our 60-bedded inpatient unit, but last year 85% of our activity and support was provided in the community, which is something that people don't often think about. They think about the hospice of just being that building. There's some really important specialist work that goes on there, but 85% of our activity last year was in the community, which is in effect that shift left. We also have supported services around rehabilitation, and our care at home team would go out and support people in the community with personal care, who are eyes and ears for our specialist teams, and can react really quickly when there is that change and deterioration with people. So, I mean, in summary, for me, it feels like we're where the ICB want the rest of the hospice sector within the area to be, and there should be learning from us in terms of what we've experienced over the last 10 years as a real trailblazer within palliative care.
Thank you. I'm going to pass to James, and I'm going to bring the committee in so that you can all ask your questions, if that's okay. James.
Yeah, thank you, Chair. And I think just to reflect that, again, thank Joanna and colleagues from Mountbatten. I mean, the tone in which they've entered into the discussion today, I think, should be commended, because this is clearly a very challenging situation. And I think both Duncan and Paul reflected that the key thing at the moment is we're in dialogue, we're in active dialogue. And I think in the past, perhaps we've been criticised for not being active in that dialogue. I'm Director of Primary Care and Local Care. Committee will remember me on issues of dentistry and general practice. And I think you've made the challenge, Joanna, in your report, and I think you've made the challenge as well, Paul, in terms of how we understand the island and the impact of the island. I know certainly in terms of what I planned around dentistry, we've absolutely taken into account local circumstances, local issues. So I just wanted... Okay, fine, but just, do you want me to... Okay. Yeah. So just to engage and reflect in the right spirit, a few things to update on. I think clearly since June, where this became in the public domain, I personally picked up the issue. So I've met with the hospice, and our Chief Finance Officer met with the hospice in June. In that meeting, we agreed a series of negotiations and conversations around a range of issues. In terms of what I could do immediately in that setting, I think one of the decisions I made is I recognised that perhaps the pace of financial change was too fast, and some of the wider circumstances need to be considered. So within that, I was able to agree the additional funding to the end of the financial year. And in addition to that, recognising some of the good practice in the hospice as well, we funded the lymphedema service to continue. So I thought that was really important in terms of giving the hospice certainty, but also making sure that we give each other space and time for dialogue. I think colleagues from the hospice will agree that the dialogue is challenging, but it's constructive. We meet on a fortnightly basis. We meet in person once a month. We meet via Teams as well. We've got a real track now in terms of meetings, so we can understand issues, we can exchange data, and we can start to really understand what we need to do and what we need to address. And I think in conversations, I think we all recognise that there are things that we can look at differently. There are service opportunities that we need to consider. And there perhaps is a bigger opportunity now than there was in June in terms of things like neighbourhood health as well. The other thing, and I don't want to stress this because you're all very much aware, because as a local authority, you have to make really difficult decisions when it comes to public finances. We are in a very challenging landscape financially. As an organisation, we're in recovery support. But we recognise that affects all public services. And I think, Chrissy, you made a good point in terms of starting to truly understand the impact of decisions, not just in terms of the money you save, but also the opportunity lost and the impact on other services. So I think some of the debate we're having at the moment is to truly understand the value that the hospice brings in its widest sense. And I'm not suggesting I didn't understand that previously, but Duncan, Chrissy and Paul make really good points in terms of core service provision, but also the impact that could have around reducing A&E admissions, reducing time at GP, reducing ambulance call out. So your challenge earlier, Chair, in terms of how we're funding this and what we base it on, I think what we're trying to do at the moment through our conversations is to create a richer evidence base by which we can understand the service model, the potential impact and what the cost of delivery is. The other point I will make, and it's out of the hospice's control and it's out of our control as well, is the national NI increase on hospices in general practice has had a significant increase impact. I think for yourselves, it's £500,000 per annum. So there are other financial pressures at play and we recognise it. So I think I've talked about that. I think where we are currently is that we're agreeing a track by which we can understand what the contract model needs to be for next year. Within that, it is about understanding costs of service delivery. I think the other thing I'm aware of in conversation with the hospice, I do think the hospice are bearing costs that could be met by other organisations in the system. So one of the things we are thinking about is how do we support the hospice as the commissioner in terms of managing some of those cost pressures. And Paul makes a really important point. What's the opportunity for the future? I think the opportunity for the future is neighbourhood health, it's service integration, and it's a new model of care. And we are entering in discussions in that spirit as well. So just to give you assurance, we are in dialogue. We have acted on the immediate risk, and we are committed to moving this forward and get into a point of resolution in the future.
I am going to open this for questions. I do have a few questions, and I will go back to. Can you turn your mic off? Is that okay? Thank you. What I will do is open it. So, hands up. So I can. Councillor Nicholson first. Councillor Red, Sarah. Has anybody else got any questions to put you in line, or I'll bring you in as and when you have a question. Councillor Nicholson.
Yeah, I'd like to ask James and the team from Mountbatten, has anybody carried out an economic impact assessment, not just of supporting the hospice, but of not supporting the hospice, because it sounds as though somebody ought to. And I'd also like to ask James if in the considerations for expenditure on the Isle of Wight, do we take into account giving the Isle of Wight an equality in its expenditure against an inequality of demographics? So 2 questions.
So I think 2 questions, but one theme in terms of how do we determine the sort of the funding model? Yeah. So I think one thing that's been really striking for me is that in recent conversations is recognising the entirety of the service provision from Mountbatten and the impact it has. So I do think we've got a richer evidence base, Councillor Nicholson, by which we can determine cost of service delivery, impact on the system. And I'm always focused not just on the cost of doing something, but also the cost of not doing something. I'm not going to suggest we're there yet, but I know Duncan in particular is starting to think about the type of data that the hospice can provide, the data that we can provide. And it's not just what we do as a commissioner and what the hospice do is in isolation. It's what does the ambulance trust see? What does A&E see? And I think you made a really good point earlier, Joe, in terms of the impact on the wider community as well. So we are having that conversation. We're committed to landing on the right evidence base. And I think at that point, we should get to the stage where we are landing on the right funding model. I think you're right to call out the difference. There's always a difference in negotiation, but we really need to understand what's driving that difference and what the evidence base is. So we are looking at local issues. Population health is a key priority. That ultimately means we've got to determine what we fund and what we commission based on local need. So there is that opportunity to think about how we fund services. But I would remind you of the fact there is the Integrated Care Board across Hampshire and the Isle of Wight. We've also got to look at our service model.
As long as it's not a one-size-fits-all, James, that's what I think we're worried about on the Isle of Wight, because we are different, in case anybody hadn't noticed.
Thank you, Chair. James, I've got a question and I've got a follow-up question, depending on how you answer the first one.
In the report you provided, you've mentioned £365 per day uplifted locally to £372 per day per day of care. That seems to suggest that was that the figure that the ICB came to before, and that was the amount that would no longer be funded because of that figure. What does this mean?
So I'm sort of reviewing this. I think that was the starting view in terms of that benchmark figure. I think the challenge we've got there is we talk about a day, a unit of hospice care. What it doesn't readily make the distinction between is specialist hospice care, i.e. someone in the bed and the care they provide at home. So I think one of the things we're trying to do is unpick that and understand what is the cost of that service model. There's always assumption, of course, if you do something out of a bed or out of hospital, it's cheaper, but often you need to provide more care in the community, and that requires more complex input. So that was our starting view. Clearly, we're in a negotiation and we need to get there, but we're working that through. But that was our starting position.
Okay, so I think it's still relevant for me to ask the second question as it's the starting position. So I looked at the study that you've cited by Professor Fliss Murtagh, I'm sorry if I butchered that last name, Murtagh, from 2023. This report seems to suggest that the research is quite recent for the costs, but when you look into it under the work stream 3, which is the time that they looked at costs for hospices, it was actually collected between 2015 and 2016. So that's where they got to the figure of 365. We all know how different financially environments are between then and now. I mean, you cited the national insurance increases, but Hospices UK said between 2022 and 2024 alone, costs increased by 20%. So I would say that as a starting figure, that's really quite out of date.
Yeah, and I think you know that's the point you make, and clearly we need to look at things like inflation and cost of service delivery. So there are other factors to play in. I think, and again, Paul will know this. I think that research is ongoing actually. So whilst that is a figure at a point in time, I understand that Fliss is currently doing research. That's an annual view, and there's a rapid look at sort of costs and impact. So I think it's a live study. It is a view. I mean, the other things we would take into consideration is the view of an academic or a professional in that regard. But clearly, we also need to take into consideration any other market comparators, any other provider type level information we can bring into play. But what I will say is that's the debate we're having at the moment. What is our starting point? And if we land on a starting point, what does that mean for contract value? What does that mean for service provision? And what does that mean in terms of our arrangements moving forward? So I'm not seeking to get away from it, but this is a live conversation and we need to get to the right point.
I think Duncan would like to add something to that.
Yeah, so in our meetings, so James is aware that we're not happy in terms of how that's quoted within the paper. So it quotes that it's the mean figure. So the mean figure is £716, not 365, which is the median figure, which is quite a difference. And we've been in contact with the author, who's well known within the palliative field, and she confirms it should be the mean figure that is used in terms of calculating cost of the service. So there's quite a difference in terms of that. But we're talking that through, and James is aware of that. But yeah.
Councillor Gladwin.
Will we hear about how the NHS has received a lot of extra funding, and we also hear from the Health Secretary, who has said that there's been big savings made with effectively abolishing NHS England. So I was just wondering if some of those funds could be diverted to cases such as this.
I think that's a very, very good question. In terms of current position, majority of providers are at a flat funding. There's been not much growth. We have seen an increase in primary care, so the primary care contract has increased, and that's in line with government priorities. The abolition of NHS England, whilst it's planned, and equally the reorganisation of ICBs, whilst it's planned, is not yet landed in terms of date. The other thing that we are doing is we're setting our commissioning intentions for next year. And we know nationally there's a big focus on how you can shift resource from the acute sector into the community to provide more services. So I think your question is well made in terms of will that create an opportunity to fund services differently? Yes, it will. But clearly, we need to go through a process of prioritisation in terms of what that means for neighbourhood health. The other issues you refer to are not yet set. Therefore, we can't quantify the level of fundings and whether they would be reinvested. But I'd imagine the Treasury will have a view on that, and clearly we'll be earmarking that for other things as well.
I'm going to bring in one of my questions, if that's okay. So this topic and how things are funded when you are looking at a bigger area and whether the Isle of Wight calculations need to be tweaked because of our demographics is very strong at the moment because of what is happening with devolution, etc., and how if we go into a mayoral system, how things will be funded. Will the Isle of Wight demographics be taken into account when you're sat at a table? It's a very important decision at the moment, and it highlights the fact that actually we have a hospice here who is very different to the mainland. So, for example, we would like to know: do you take into account we have no Macmillan service here? Our hospice is everything. So, and actually having had several members of my family who have passed through the hospice, I have to say that they do everything exceptionally. And I think anybody, most island residents at some point their lives have been touched by the hospice. But as I said, it is very big conversation here for councillors because we need to know that actually if we go into a devolution deal, will we suddenly be in this situation that funding formulas are aimed at other areas that actually aren't taking into account our elderly population? The fact that some services aren't available on here, such as Macmillan, that are available readily on the mainland. So it is very important to us that we know at some point that the island is being listened to and that things can be tweaked, that we're not actually going to have everything written in stone going, well, do you know what, we're not taking into this count. So I think, that's a bit that we need some reassurance that you are having these conversations, but you are open to actually taking into account our demographics, and there can be something that can be done. Otherwise, I think the impact of this will have a wider impact on those bigger discussions on bringing services, funding down from Westminster to a mayoral system. If we can't get that right, this right, then it's really worrying. So just a little bit of assurance would be nice that we get to the end of the conversations and not get anywhere.
Notwithstanding we're talking about a particular service, I'm conscious that this is a concern for a range of healthcare services on the island, and I'm also conscious that it's been an ongoing concern and one we probably need to have a debate on. So I'm happy to take that back, Chair, and perhaps come back with a view in terms of, can we look at data differently? Can we model differently? I think we've got an opportunity now because we'll be setting our commissioning intentions for next year. And I'm really keen at least that we share a view on what that should look like. I will, of course, make the point that clearly we need to take a view across Hampshire and the Isle of Wight in line with the resources that we've got. I think I'm not going to reference dentistry because it's not the issue, but that's an example of where we've looked at local issues and acted accordingly.
So in my little, in my head, I think what island residents would be looking at is that per island resident, you get an equal, for an elderly resident, you get the same funding as you would for other areas of the ICB. When you look at how the funding is done, I think we need that assurance that actually those demographics are brought into account, that you would be treated equally if you were an island resident or you were in Portsmouth or Southampton, you would get the same funding per head. And I think if you looked at it on a spreadsheet, I'm not the queen of spreadsheets, if you looked at it on a spreadsheet at the moment, having looked at it, that is not the case at all. And that's the bit that we're trying to drive at this evening. I'll hand over John to his question. Oh, no, hold on, John. John, then Joanna, then Joe. Okay.
Chairman, I've put the conversation, the dialogue here into my internal AI and asked it to come up with a resolution. And the resolution that it's come up with, to sum up what's been talked about, is that this committee supports constructive dialogue between the Mountbatten Centre and the ICB in the hope that it will result in a timely and stable support agreement to a valued asset and service. and considers equality of expenditure to address the inequality of demographics. Not bad for AI, is it?
Thank you, Chair. And I guess before we get to Councillor Nicholson's resolution, I was kind of just curious if it's great to hear about the dialogue. I'm really supportive of that. But obviously there are still a lot of unknowns. So as a committee, I'm kind of just wondering what when do we expect kind of more detail to come out? When do we expect some more updates on this? Considerations that have been raised around the data used and making sure it's accurate and up to date. I just want to make sure that, because I guess my concern is the longer there's uncertainty, it's not just impact on the people that we be using the care, but also the service providers themselves, the staff at Mountbatten, the worry that would cause, the worry of people on the island that are not yet using it, but may be using it in the future, and the worry that what service are they going to provide. So certainty quickly, please.
I mean, I'll answer that because ultimately I'm the commissioner. So I think we're working through a process. We're meeting regularly. I think we've got a couple of key lines of inquiry. Data is one, service specification, funding model. I'm very happy to bring an update to a future meeting if that's helpful, because I know it's a topic of interest. I think in terms of landing on a deadline, I don't know if Duncan and Chrissy agree, but that's probably a conversation with Becky in terms of how we want to position that, because there's two organisations will need a view. But I'm very conscious of the importance of certainty. I'm very conscious of the fact it's not just staff, it's volunteers, it's patients, it's residents. And we need to do this in a considered way, but we need to take the time to do it properly as well.
Sorry. I'm just coming from a Mountbatten perspective on that. So agreed, yeah, dialogue's great. And, you know, since James has been involved in that dialogue, it's been brilliant. I think the threshold, though, is really low because we've had hardly any consultation at all to date. We feel that we just need to completely rip up the service spec that's been put to us because it's not fit for purpose. So there's a lot of work to be done in a short period of time, I think is the point. Dialogue's brilliant now, however, we're playing catch up. Yeah.
Thank you, Chair. And I'm really pleased that in the last part of the conversation, we've talked about island people and their views, because I think for me, that's part of the picture that's missing. It's really easy for me to sit on the outside of this scenario and say what I do differently. And as a commissioner, I think every commissioner will say what they'll do differently until they're sat in that seat. It's really difficult. I think there is a big gap in terms of the dialogue and what's going on at the moment. And that's linking back to the people that Joanna references in her report, the people who draw on care and support from the hospice and who ultimately will be the people who receive a different service moving forward. I'm a firm advocate of co-production, of helping and being helped by people who access services to shape what those services look like in the future. And I think given how important Mountbatten's hospice services are on the island, we're missing a trick if we're not involving those people in what we're doing. So that's my observation from the outside for what it's worth. But Chair, through you, if I can extend an offer. One thing my team do really well and I'm really proud of is co-produce with our community, consult with the public. And I'd like to extend an offer to the ICB to support them in the co-production and the consultation around this really difficult subject. If that would be useful, please feel free to use us and our routes to progress that if that's something that's useful to both parties.
Just in quick response to that, if I may, I think welcome that, Laura. And I think when we talk about the service provision model, I think there probably are discussions around some of the social care elements into the palliative care space as well, and how we can be aware of that and use that in our planning.
Thank you. I just want to expand on some of the things already mentioned. So we've discussed looking at what Mountbatten provide, but it's really important to discuss what isn't provided on the island, as Councillor Mosdale mentioned. So we don't have Macmillan over here. We don't have other services that the mainland has. So it's really important to look at what we don't have. And it's also important to look at the history of Mountbatten. So what's led to Mountbatten providing the services they do? And if you look back 10 years or so, the Isle of Wight NHS Trust was providing really, really poor end-of-life care for island residents. And that's been evidenced in several CQC reports. People were being moved multiple times at night for no clinical reason. There was a very poor level of awareness when people were dying. So 10 years ago, we were in a very different position. And that's part of the reason that Mountbatten went in to provide support for the hospital. And now our hospital is providing really good end-of-life care. And CQC have mentioned in their reports that that's because of the support that Mountbatten provide. Mountbatten have also provided support to care homes, both in terms of end-of-life support, but also training and mentoring for managers and staff. And we've heard from care home managers that are really concerned that many of the people that live in the care homes are going to end up dying in hospital because they won't have the community support there. And that's the last thing they want, and that's the last thing families want. So we are quite concerned about care homes. And I'd totally echo what Laura said. I was going to ask you, James, about how you're going to engage with local people. There's a wealth of legislation and statutory guidance around the duties ICB have to engage. And there will be significant service changes in April. And first line of the NHS constitution, as we all know, is the NHS belongs to the people. And the people of the Isle of Wight want to be engaged with and consulted with if a decision is being made about a service that has supported their family and may support them. So engagement is absolutely key. You can't make a decision in Hampshire about a service that affects and most likely affects every one of us. So yeah, I'd totally echo what Laura has said, and that the lack of engagement and communication leads to a distrust of local people, and that causes anxiety and fear, and that's not what we want. And local people are absolutely, if this could have been avoided if there'd been an effective communication plan at the beginning. People understand that there are financial constraints and that we can't always have everything we want. But if there's no engagement and no communication, then that's not good at all, and that's not what we want for the people of the island.
Carl, then Sarah.
Thank you, Chair, for allowing me to speak. I'm Carl Love. I'm actually on the Education Committee. I think there's a lot of really valuable comments that have been made. People are telling me as a ward councillor that they are frightened and scared, particularly those people who are now presenting, who in 3 months' time may well face end of care life themselves. And they are particularly concerned, and that is causing them significant distress because of what they are picking up through the media and other places. It is now time critical, because whilst people talk about April, in actual fact, I'd like to bet that the hospice is going to face staff moving from Christmas. So it's not about 6 months. It's about having a decision in place which reassures the staff, the carers, the supporters, and all of those volunteers by Christmas. Because beyond that, I know that if I was working within the NHS, which I have before, I would be looking to leave. And that skill level is incredibly difficult to replace on an island. We cannot recruit in the way that they do on the mainland. And I know recruitment is difficult on the mainland, but you cannot recruit on an island. But this reaches out beyond just the hospice. So, you know, paediatric services on the island, we're still waiting for answers and commissioning around that. The same with diverse services. We're still waiting for answers to be brought forward there. And only this week, Councillor Paul Brading has written to the Chief Executive of the Integrated Care Board to ask some quite testing questions, because we have a whole, and I realise that money is difficult, but we cannot just sit. And that's how it feels because of the lack of communication. We've got a whole area of people over here who are equally as important, and we need to get on and deal with this in a timely way. And the timeline is Christmas, not April. That has to be done so, because we will lose those valuable skills, doctors, nurses, and everybody else. So it's not about 6 months, it's by Christmas, or people like me are really going to start jumping up and down.
Thank you, Councillor Love. Can I just add that there is a credit to the hospice that actually having lots of young people that I know who've recently qualified or in the last few years as nurses, the training that they've had and the experience they've had within the hospice have been exceptional. And if you could take most of them to work with you, they would love to, because actually they have all come away saying it's one of the best working atmospheres they've ever been in. And I think that brings that back to Councillor Love. When you start to have a large amount of financial pressure over you, it is palliable of Dr. Howard on how you are feeling now because of this financial pressure that's being put upon you. And that will not just be you, it will be other members of staff and nurses, etc. And people want to come and work at the hospice at the moment because they know that they have, you know, not just job satisfaction, but actually you're a really good team to work with. So I hope, you know, it is right that actually this isn't extended to a point that is, you know, people don't want to work because they're worried that there's a big black cloud hanging over them. I'll bring James in and then I'll bring Sarah in and then we will sum up.
So just a point. I mean, I've never suggested April as a close-off date. I'm personally involved. I'm in regular dialogue with the hospice. And I'm really keen to get us to a track where we can be really clear. Uncertainty doesn't suit anyone. It clearly doesn't suit the staff. It doesn't suit us either, because we want a strong, viable end-of-life hospice provider on the Isle of Wight. So just please be assured that I'm personally shaping that. I'm personally having the dialogue, and I'll personally take responsibility for timelines.
Yeah, can I clarify? Can you just clarify? The funding is until April. That's the issue, isn't it?
Yeah. So
whilst you're saying not cut off, the fact is, if I'm an employee, I can see that there is a cut off.
I get your point.
That's the point that I make. That's why it needs to be Christmas.
And that's why, sorry, I think this is important for reassurance. That's why relatively quickly, when I got involved in the negotiations, I made the decision about extending the bridging fund into the end of March. So we could deal with that and then we could move forward in terms of the service model. So I get that, I understand it.
I'm going to bring Chrissy in.
Thank you, James. And just to echo, we are working really closely with James and we're really happy with that dialogue that's going forward, but we are really concerned about the April cut-off date. But just going back to a point you made about our staff and the hanging over their heads, we absolutely wouldn't want to lose any staff, but the reality is they provide a service, and the reality is what the NHS's responsibility is when they do their quality impact assessment. They have to assure us, the public, the people that live on the island, there won't be a gap in service provision. So the reality is somebody else will have to provide a level of service, whether that's increasing district nurses, get more people in A&E, more paramedics. Our staff, they won't like it, but they'll be protected by 2P because they will have to go somewhere else. So the money will just go round and round in circles.
Sorry,
No, you're
I know, I should know. I know, I should know better. So I've got another question about the report. The question is, I'm very glad to see that the ICB weighted up how many beds per 100,000 from 8 to 12 for specialist palliative care units. But I notice it's per 100,000 adults, and I was wondering, considering that Mountbatten provides services, including inpatient services for children and young people, is that separate to this funding or is that included?
One of the issues we're looking into is at the right level of comparator, so we may need to adjust that. I'll come back on that point if that's okay. A fair challenge.
Put that in writing to the committee, can respond in writing, is that right? Yeah, thank.
Well, I note that a 996,000 emergency government grant was awarded in July of this year. So I was just wondering, why can't another grant of 1.4 million be awarded, and then that's the problem resolved for the good of the island and everyone that relies on this service? Thank you.
Yeah, I obviously can't answer for the government, but clearly local MPs will have a view on that. And I'm sure they're making those representations as well.
I think the point is as well, we need secure long-term funding. That's where we need to get to. I think that's an excellent idea, but we do need to get to a point that the hospice knows that they have security in the funding and they can get on with doing the job that they're really good at, which is, you know, looking after our island residents. Stop clicking that pen, Councillor Nicholson. I can hear it. I have got the most sensitive hearing. Councillor Nicholson, could you read out your recommendation, please?
There's very little we can do but support and encourage, and I think this resolution might just do that. This committee supports constructive dialogue between the Mountbatten Hospice and the ICB in the hope that it will result in timely, Carl, and stable support agreement to a valued Isle of Wight asset and service, and considers equality of expenditure to address the inequality of demographics.
Joe, Councillor Lever.
I was just going to say, Chair, just harking back to what Joanna and Laura were mentioning before, I just wonder if we can add into that and encourage dialogue with communities as well, just make sure that's paramount.
Yeah, I think we need to add that because I think that is really important, that, and you know, that we do need to, that consultation with island residents, you know, is really important in this process. If we can tweak that, and I think we'll get Dem Services to tweak it, but as a recommendation, I'm quite happy to second that. Would you all like to move to the vote? Thank you. James, please don't go yet because I want you to add something on dentistry. Some good news. Yeah, is that okay? Would you like to just wait 2 seconds just while James does his dentistry thing, because then it makes it easier before everybody goes. Thank you.
Yeah, so I just some positive news in terms of previously this committee, I've talked about the need for us to procure additional dental activity for the island. So we undertook a procurement exercise at the tail end of 24 for 44,000 UDAs, and we have found 2 new providers who have started to provide that on the island.
Public listen to this meeting. Can you
units
UDS?
of dental activity, sorry. And we're just in the process of procuring an additional 24,000, which will bring the total up to 68,000 UDAs. Within that, we've got 2 new providers who appear to be very committed to the island, one of whom has submitted a planning application for a 5-surgery dentist in Ryde. So I'm confident at least that we're turning the corner and we're changing the landscape. Still a long way to go, but I think it is positive that dentists want to come here and they want to provide services. So I just wanted to make that point before I leave.
Thank you, everybody, for your time. We completely understand where you are, and I thank you, Laura, for offering support and help to try and get to a resolution for this. And we will be on this. This is not the end for us making sure that this is scrutinised and looked at on behalf of island residents. On behalf of all the committee and all island residents, just thank you for everything you do. It is so important to be able to end your life with dignity and know your support in, you know, in in the right surroundings for whatever helps you personally. So from all of this committee and Island residents, once again, we just thank you for your time and everything you do. Thank you. Thank you. And now we go on to the decisions part of the meeting. And I'm going to open it up with the Adult Social Care Statutory Adult Complaints Report, pages 24 to 25, pages 35 to 44. And I will let Laura Gordian introduce the paper.
Chair, could I just, sorry, just quickly, we're just waiting for, sorry, Laura. I believe we're just waiting for Councillor Price to come back into the room. I think that's what Simon's gone to go and check. Sorry, Chair.
We'll continue. Thank you, Laura.
Thank you, Chair. The report that the committee has before it is not an unusual report for the local authority, and certainly for the 10 years I've been with Adult Social Care, the report has come on an annual basis to the appropriate governance group for oversight. But for information, the complaints process that applies more generally to the council has almost a special arm attached to adult social care, where there is a statutory complaints process that runs alongside. So whilst adult social care complaints are reported in the corporate report that went to the Policy, Finance and Resources Committee earlier this month, it's important to me that you're cited on the specifics around adult social care complaints. I think it's important that I'm very clear from the outset, and as strange as it sounds, I actively welcome complaints about the service that my directorate provides to Island residents. It sounds a bit odd to go looking, but actually those complaints help us to build on the strengths that we have and to put in place development opportunities where we know that there's gaps. We embrace any feedback that comes into the directorate, and it's really important that the people who take the time to feed back to us their concerns or their praise have that properly acknowledged. And this report is part of our way of ensuring that the complaints we receive are properly acknowledged, and we can demonstrate to the wider public, to Island residents and to the council, that we take that very seriously and action those complaints. The report is here for noting. It provides a lot of data, and I'm certain that you've all had the opportunity to consider it. I'd like specifically to draw your attention to the paragraphs around learning from complaints, because for me that's the most important part of what we do. And you'll see set out in the report the steps taken to ensure that where people have received a quality of service less than I would hope for them and less than they expect themselves, action is taken to address any gaps in the service that we provide. I could talk to you for hours about the information contained within the report. I won't. Save it to say I'm very happy to answer any questions that you have in relation to the detail, and to also say I'm incredibly grateful to Helen Babington, who is the complaints officer within the Adult Social Care and Housing Directorate. Helen does a brilliant job to ensure that the voice of local people is paramount to the work that we do, and has pulled together this excellent report for your consideration this evening.
In fact, Councillor Nicholson.
Yeah. Laura, I noticed that half of the complaints weren't upheld to go forward to a formal complaint. Was there any constructive outcome from those complaints, and could you give us an example?
Of course, Councillor Nicholson. So wherever possible, we'd like, although people are encouraged to complain to us, to deal with their complaints ourselves rather than them needing to be escalated to the Ombudsman or to other people to make a decision. We operate a process whereby informally we seek to resolve the complaints that people may have, getting together around a table with them, with their advocate, with people who support them to say, okay, we got it wrong, how can we make a difference? And it's largely through that process that complaints don't travel forward. Where they do, it's because we can't agree. And sometimes having somebody else to support us in that space to say, okay, this is where you need to come together. This is what needs to change. This is where council, you've not met with your duties, or person, you're not accepting that the council has, is incredibly important. With all cases, whether upheld or not, the learning pattern and the learning takes place as part of that process and is taken back. We've had a number of complaints in the past that haven't been upheld, and they've not been upheld for a variety of different reasons. We tend to focus on the ones that are, because that's where our biggest learning is. Where complaints aren't upheld, it's often a breakdown in communication between my team and the person themselves or their representative, and we've got our wires crossed, or expectations haven't been met because those expectations haven't been managed. And for us, focusing on our communication and the way we work with the public is incredibly important.
If I may, Chairman, so in that latter case, would that then feed back into the system for, say, for example, clarity on expectations?
Absolutely. So in the past, that's led to us reviewing our letter templates, changing them where they've not been accessible to people. It's resulted in us altering some of our processes so that we change the process to adapt to meet the need of the individual or a group of individuals, because one person's experience may be the same for others. Where we have challenges around verbal communication, and what we use is a space called So What within my department. It's almost a you said, we did, and this is how the outcome changed. And that So What forum enables a really open discussion with professionals around where we've not quite got it right and how we could tailor that. I'm very keen that as part of that process, we steer clear of operating a blame culture. So it's an incredibly reflective and supportive space intended to help practitioners to move forward with their practice rather than pointing out where they've perhaps not got it as right as they could have done.
To be honest, Laura, that was a trick question because I didn't expect anything less.
I noted point 23 that there was a white care system failure in raising an alarm, and I just wondered if you could just explain what actually happened, and hopefully there was not an unfortunate conclusion to that failure. Thank you.
Of course, Councillor Gladwin, and unfortunately, where we have systems, those systems can on occasion fail. It's no different to at home when your telephone line goes down or your Sky drops out. Unfortunately, the consequence of that for a person who needs support in their own home, who's pressed their buzzer, is quite significant. In this specific case, I'm not aware of the outcome. I'm not close enough to it, save to say that steps were taken to ensure that the person remained safe, and we worked with the family. There was a difference in terms of the local authority's view and the view of the family and the individual, and that's what led to the complaint being escalated and being upheld. On receipt of the findings of the outcome of that complaint, we've done a deep dive into the service to make sure we've covered off what we need to. We're switching our processes from analog to digital as part of the national switchover, and we've recently gone out to tender for new equipment providers so that we know we've got the best quality equipment operational in all of our services at the same time. In addition, as part of what the White Care team do, they now operate a process where they randomly test these scenarios. So we're doing almost ad hoc testing with people in their own homes, and also asking care providers if they're visiting to press a button to see that it works at that point in time, so we can manage that process. I wish I could sit here and tell you it would never happen again. I can't, because technology isn't 100% reliable, but what we do is our best to ensure that it doesn't.
Yes, thank you. And I'm very encouraged that you actually use the complaints constructively. Thank you.
I think we're all happy. As usual, thank you ever so much, Laura, for just giving such very concise answers to the question, and feelings that actually sometimes it is good to complain because those complaints, can actually make changes that you need, and it is good to hear that you actually do like to hear that and take it on board. There's nothing worse than anybody sitting in a room and going, well, I don't know why they complained in the first place. So thank you, that was really appreciated. Councillor Gladman.
Could I just add that I was encouraged that the amount of compliments greatly outweighed the complaints. So that's obviously you're doing a very good service. Thank you.
I'm also greatly encouraged when the number of compliments outweigh the number of complaints, but there's learning there too.
Yes. I have to do this bit, so Councillor Edwards, just press your button. Just have to do this bit. Are we all happy that the committee notes the report? Yes, thank you. Before we move on to the next part, which my understanding is, as I flick through my papers, is Councillor Learning and Development. I think this would be a appropriate moment if the lady in question could move forward and introduce herself, which is our new Director of Public Health. I think that we should give a few minutes. And just, I think it would be really useful to see any ideas or differences and things like that. I know it's a bit of offbeat and off the agenda, but I think it would be worthwhile for you to all be introduced to Kate. I let over to you.
Thank you, Chair. Offbeat, off the agenda and unprepared, so you'll get it from the heart. I am Kate Harvey. I'm the new Director of Public Health for the Isle of Wight. I'm on day 9 today. And it's a pleasure to meet you all and to get to see the way that the committee's functioning.
Sarah and I have both have separate meetings, haven't we? And we have absolute assurance that one of the things that's going to be top of the list, isn't it, is making sure that we do have a really robust domestic violence strategy in place. So we've both brought that forward. Thank you. If you sit there, because I think it's very important you sit there as well, because we are coming to Council Learning and Development and then the work plan, so it'll be quite useful if you move forward slightly. Thank you. Does anybody have any quick questions? Or Kate, we're not going to put anyone more pressure tonight. You lot are so kind, so kind. Right, I'll hand you over to the next part of the agenda and introduce Sarah Teague, who's the Strategic Manager for People and Organisational. Who makes these titles? People and Organisational Intelligence. And that brings us on to the part of the agenda, which is Councillor Learning and Development, pages 45 to 56. Over to Sarah.
Thank you, Chair. Thank you, committee, for having me here and hopefully reading the paper in advance. So this report is in support of the Constitution agreed in May, which set out the need for councillors to be provided with the necessary learning and development that they might need in order to help support the decisions that you're making. So what we plan to do is set out the learning and development that's general, essential learning. We can't mandate learning for councillors, but we do recommend and say that it's essential over a range of subjects that's for all councillors. And then specific to councillors on this committee, I have worked with Laura and Public Health to determine an initial set of learning that would help that would help in your decision making, and then hope that this is becomes a regular part of the agenda and that you highlight areas that you might want more learning and development in. We will also be reporting on uptake of the learning so that you and the public can be assured that you are doing the appropriate learning. This report is going to all committees, has gone to PF&R on the 4th of September, and just for information, was unanimously agreed. No pressure. Any questions I'm very happy to take. Thank you.
I have a quick question. Having been a school governor and you basically do lots of online learning, I'm a bit of a geek and I like the end of it when you get a certificate. Are these courses online, and do you get something that records that you have done that? And is there just something like a Q&A at the end of it to say, so that you know you've actually understood it? How do we access those and stuff like that? It just wasn't clear when I read the report, and I do like a certificate.
Okay, so all the learning, not all of it is virtual or e-learning, but the majority at the moment highlighted is. It is all on the Learning Hub, which is available to you. You can download certificates and there will be a record of learning. You can also upload any evidence in your My Learning section that of any learning that you might undertake over and above what's considered essential that you've done because you're interested committed people. So you can also upload that so that your record of learning is complete and shows that.
Councillor Lever and then Councillor Redrup.
Thank you, Chair. I think this is really good, and I think hopefully it will give the public confidence that the councillors are competent in their decision making, which may be questionable sometimes, I don't know. But one of the things, because this came up on pensions as well, I was keen to understand, because the committee had some feedback about the pensions training. I was just wondering, is there like an official route to feedback on the training for councillors and to potentially make improvements or make adjustments and things like that? And how do we go about that?
So you can directly email me, absolutely, to give feedback. What we have had in operation is a councillor development group. We've kind of paused that for this year, but Councillor Nicholson was on that, and we will start that up again so that there's a regular discussion with councillors about learning and development. But absolutely, if you've got feedback, please direct it to me. Thank you.
Thank you very much. I'm glad to see that our committee has the longest list of training. And I may have to Laura for that.
Why is that not surprising?
But I have a suggestion to make it even longer. And that's domestic abuse awareness. I think that would be really useful for this committee.
Thank you. We'll add that straight away.
Really good. Sorry, one last question. So just to check, these are online courses that you do at your own pace at your own time. It's not like a scheduled in.
Yeah, so the essential ones are all online and absolutely do that in your own time. And then the one that you have recommended is about attending the conference, which obviously would be a day, and then that would be to your availability. But yeah, most of them are to be done when you can, because we know that you're got busy lives too.
Councillor Gabber and then Councillor Jeffrey.
Just looking at this, I am a little bit uncomfortable at point 12 and 13, where it says about potential personal reputational implications not undertaking key learning activity. And, you know, I was just concerned that it's not going to be sort of like used to sort of like shame people publicly. Because that's sort of like how it comes across. And, you know, somebody may have legitimate reasons for why they haven't done the background reading. And I just think that to be checking up on people every 3 months, it could be a bit heavy-handed. So I was just hoping that you might explain the sort of intention behind this. Thank you.
Yeah, certainly. And again, down to you to suggest alternatives for that. But it's about some of the learning and development is questioned by members of the public. And when decisions are made, there are questions that come in, you know, have councillors been trained in this? Do they know? And so this is for you to be able to give some assurance, I suppose, that there has been a basic level of learning undertaken. But yeah, we don't want to get into a naming and shaming, but we need to get to a point where you feel strongly compelled to do some of it. So I suppose it's getting that balance right. Yeah.
It's a bit like, I do think anybody, this committee especially, will have large we've only got 3 meetings left, but we will have stuff that comes on, you know, with regarding to procurement. And it's really important that everybody on the committee understands, you know, the complexities of local government procurement. Hence why I push for everyone on the committee to be able to do that, you know, at least have a level of understanding of it. I do think it's really important. And now that we know that it's on the hub as well, that would be really useful to do. Councillor Jeffrey.
Thank you, Chair. As a new councillor, and sort of I've been thrown in at the deep end, so as to speak, as a substitute in here, I think this training would be certainly very, very useful for me. I'm already on the planning committee, and we did planning committee training on that as well. So I think it's very, very important for all of us to actually learn this. Thank you.
Councillor Nicholson.
Yeah, I can say that as a member of the Council Development Forum, it is a very useful forum, and I know that Sarah's taken on suggestions. One of them was to raise awareness of unconscious bias as councillors. We must be aware of our natural biases. Another suggestion might be, and it is very pertinent, and it's something that we're guilty of in this country in particular, and that is to take heed of Bloom's taxonomy, the principles of Bloom's taxonomy, which are to make an assessment of somebody's level of knowledge, understanding, and competence before matching it with or charging them with responsibility. And this was cited in the fallout from Grenfell, where right from the top, people were in positions of responsibility and they didn't have the, not their fault, that they didn't have the competencies to match it. And it's something that we should be aware of as councillors, and particularly the signs of when somebody is in a position of responsibility and doesn't have the competences, because there are specific telltale signs that if you're aware of, you can do something about.
Just that it's wonderful to hear Bloom's taxonomy quoted in a committee, service committee. Thank you very much.
I've been walking on the top of Venter Downs having a conversation with Councillor Nicholson's why he's telling me all about Bloom's taxonomy. Yes, very interesting.
I use it at work very, very effectively.
So the recommendation is that the committee approve the content of the report and begin to undertake the learning and development required of them. Any new learning to be added to the committee requirements should be discussed and agreed by committee members. Are we happy to just go to the vote? Thank you. Are we happy? Committee work plan 57 to 58. So is everybody happy with the future work plan? Is there anything that we want to add to the work plan? Kate, have you had a chance to look at the work plan as well?
I have. I was hoping to bring the suggestion around domestic abuse. If I can give some context, having started in post 9 days ago now, domestic abuse is a really important area for the island, really important topic that I share your passion and commitment to. There are some examples of great work on the island. Having started, what I'd like to do is actually do some additional work to make sure that we can add to the detail that's been previously discussed through some of the prior scrutiny arrangements. Specifically, I'd like to address some of the points that were raised, making sure that there's a clear summary of who's involved, where we're starting, what will be delivered, and what will tell us we get there, that the work has a really clear focus on all levels of prevention and need, and that there are really clear messages for the public, including how to access support. So to do that, I'd like to suggest to the committee that I have time to raise further discussions with elected members, with health partners, with police and others involved in our local domestic abuse prevention and reduction of harm system on the island, and also with the Island Survivor Voice Forum that's launching next month. It's really important we get this right. I want to make sure that actually we have something very clear. So my suggestion would be, if feasible, that can come back in the new year, potentially taking the place of the Director of Public Health annual report item, which may be more appropriate slightly later.
For that or December? Would you be able to do it by December, or is that too much pressure?
Potentially, I'm mindful that the very first meeting of the Domestic Abuse Strategic Partnership Board that I'll be chairing is the very end of October. The Survivor Voice Forum will only be starting and launching their first meeting in October.
Yeah. I don't want to drop the Director of Public Health annual report because it covers so many different areas. Councillor Nicholson.
Yeah, I was just going to ask, Kate, are you aware that Southampton University has developed a life choices game, and it has been rolled out on the plan? It was rolled out through the Council North Place plan, but it takes young people through life choices and then teaches them what the consequences are, and apparently it's a real hit.
Sorry.
That's really helpful. I'm not aware of the game. I am aware they have quite extensive research into domestic abuse, and I will look into that, because as part of the early prevention and looking at gender-based violence and concerns more widely in our community, actually young people and schools are really key.
I'll put you in touch.
So I don't want to put you under any pressure, but I would like the Director of Public Health report to stay where it is. The agenda for it is really important to all of us. Can I say we would like to see it on the 18th of December? If you are really under pressure, come back to me, and we do communicate all the time. We've got an email system that goes to all of us. If you're really under pressure and you can't bring it, there is quite a lot of work that's gone to date. So it would just be really important to us that we see this during this term, that we actually get to a point that we can agree a strategy. This committee will always understand that this will be an open document, that it won't be the full and final strategy. But at the moment, the last one we didn't feel was quite there yet. That's a subtle way of putting it, isn't it? Quite there yet. So I think we'd all be in agreement, wouldn't we, that it comes to the 18th of December, and then we understand that it is a working document and it will carry on moving. Sarah.
Yeah, I think looking at how many items we've got in February, it's really important that it gets a good amount of time. So it would be really difficult to give it the amount of time considering what's already on there. So if we can aim for December, and then if not, or perhaps an update in December, and have it as an update rather than as a decision, would that be a better sort of compromise?
In my book, a decision is to be noted, because you still have made a decision by saying we're going to note it. Laura doesn't agree with me, but we don't have to agree on everything, do we, Laura? Is that okay? Would you mind, Kate?
Thank you.
Sorry to put you under pressure at your first meeting you've attended. Is there any other queries with the work plan? She's going to throw something at you, Laura. 40 now, the press have gone.
As Kate's given up a slot on the 30th of October, might I be able to steal it? I'd really like to bring within the right year the Safeguarding Adults Board annual report. It normally is very much delayed and you get it a year later. But since we've changed the arrangements for the Safeguarding Adults Board report, I've seen the draft. It will be signed off by the board early October, and will be available for the committee by way of update for your meeting on the 30th, if that's something the committee would like to see.
In October, what is the scrutiny?
Well, I was going to say to you that there are 3 health scrutiny items on the plan that are all TBC. There is nothing set in stone, so I was hoping you might tell me what you would like to be on the agenda.
Councillor Lever.
I was just going to suggest, Chair, I don't know if we need to discuss it first before we commit to a day, but I'm just conscious of the item earlier with the ICB and Mountbatten, and obviously wanting fairly regular updates, I think. And the point that Councillor Love really hit home about Christmas being a good indicator about how things are going, whether we want to bring, it doesn't necessarily need to be as large a forum as it was just then, but at least a sort of, some sort of update.
I think it would be really good. James was really approachable. It'd be really nice if we invited him to come and give us an update on a variety of things. I think that would be really useful, and then we can ask him questions, because he can't attend to it. And I think maybe the questions that they've asked from children's as well, that we could ask children's to overlap and just come and say, we've got someone from the representative for the ICB, just a few questions and topics that we just need knowing that, and get some feedback back, because I know children's have raised some with the ICB as well. So that'd be one of the things that we would do. I do think at some point we do need an update on mental health services, and feeling, you know, there's lots of work going on at the moment, but maybe having a Sropia and people like that here to just find out how they feel their services are going. Whether that would fit into October and we could organise that, would be, you know, I think that would be that linked of where we're going with our drugs and our alcohol abuse and the mental health services, and maybe have a bit of an update where they are at the moment, as a health scrutiny. I think while we have this opportunity to do it, would everybody happy with that? So an update from the ICB, and then maybe have those interlinked services of the drugs and alcohol and mental health, and an update and a bit of scrutiny and questioning from us in October.
Sorry, just to clarify, so it's for the October one,
Yes.
it's addiction services
Yes.
and mental health. Okay,
Yeah.
yeah, so not generic mental health, but
No,
addiction
and
services.
mental health, how they are linked. Because if you see so much stuff that's coming up in, you know, local media and stuff like that, a lot of the crime and stuff that we're having on the island at the moment seem to be linked with, when you read the magistrate reports and everything, it's linked to alcohol, drugs addiction and mental health services. So I think it would be really good for us to have that feedback, and it brings it to the public domain as well for residents to understand that movement is happening, or not, as the case may be. And then have him just to come and give us a quick update. Yeah, I think Joe's right that actually we can ask James to come along. He's very approachable. We were reasonably good with him, but I think this is such a hot topic that we could just say to him that he only has to say for 15 minutes. Is that all right, Mel? That we just want a bit of an update. There's so many things going on, you know, that overlap everything. We just like to hear it from. It's easier to ask a question than end up with email after email after email. It's nice always to see the whites of people's eyes, isn't it? Well, I think so anyway. Do we have anything else to add? Are we happy with that? No, we're all happy. There is nothing else to add. I now officially call this meeting to a close at 18:37. Hope you all have a safe journey home.